Welcome, welcome to Health Issues. I'm your host, Chris Sylvain, and so excited today. It's probably, he's been on a few times before, but for whatever reason, it's just so much more exciting today. Who you have here is the founder, the original, the one who created Health Issues, the same plant, same everything that you see right here. He designed it, ran it for years, and so graciously, said, hey, Chris, go ahead on and run with it. We want to thank and get excited about Dr. Ferdinand. Thank you, Doctor.
How you doing, Elder Sylvain?
Oh, I am doing fine. My mentor, my friend, and we're actually here to work to talk about some things. But I think for everybody at Health Issues, some people may not know, and we'll find that out. Those that have been in the city for years knew that you created it and designed it, the whole concept. I go all the way back to when you were on the radio. It'd be Habarigani. I never forget, hearing that.
Yeah.
But an activist in the city, major throughout. But I think more than anything, people have to appreciate what this man has done, what he's continuing to do. He just gives and gives and gives and gives and gives. And so we appreciate you, Doctor.
I'm very happy you're able to keep it going, and I know you've expanded. You're doing a lot of things in your personal life. We were talking even before we came on, you're trying to get into preparing healthy meals for our people, good soul cooking without a lot of salt, that kind of stuff.
That kind of stuff.
That's wonderful. Yes. That's wonderful.
Yeah, healthy soul food in the pharmacy. Who can believe it?
Wow.
Yeah, so it's good. It's good. And yeah, we're doing that. But let's talk about what we're here to talk about. We're here to talk about arrest the risk.
Yeah, it's a funny term, arrest the risk, because people think arrest, they think of handcuffs.
Okay.
Arrest means really to stop something,
okay.
And the risk is the risk of sudden cardiac death. Sudden because it happens like that.
Okay.
Cardiac means heart,
okay.
And then arrest is when the heart stops. And if the heart stops, you die.
Oh.
This is very common. I'll give you some bad diseases: breast cancer,
okay.
Lung cancer, AIDS.
Right.
Sudden cardiac arrest is more common than all those conditions.
Nobody would even understand that or believe it.
Well, anecdotally we do. If you talk to people, they'll talk about their father who died suddenly while watching television, okay. Or their aunt who had a history of congestive heart failure and then died suddenly one day. So people kind of know it,
right.
But because it's something that often is without symptoms, 95% of people who have sudden cardiac arrest, it happens suddenly and they die before they get to the hospital. For that reason, almost it's something that we kind of institutionally recognize, but you're not in the hospital, you're not in ICU, you're dead, so it's kind of put in the back burner.
And it could be almost anybody in a sense?
It could be. Most people have underlying heart disease.
Okay.
It's not the same as a heart attack. Now, a heart attack is when you have blockage in the vessel itself.
Right.
You can have it associated with a heart attack, and most of the people have some underlying heart disease.
Okay.
You also get it with congestive heart failure. Now, with congestive heart failure, the heart's not pumping strong.
Okay.
It's often enlarged and kind of weak in its pumping action.
Okay.
The electricity goes awry. Okay. So whereas the heart attack, think of it as a plumbing problem, think of this as an electricity problem. So the electricity goes awry,
right.
The person can go to arrhythmias and the heart starts beating really fast, and then they can straight lie.
Okay.
If you're not in a hospital or you don't have an implanted defibrillator which shocks the heart back, right. You die.
That's just it.
Yeah.
So a heart attack, that's when you have the gook in your heart.
Yeah, and that blocks
everything.
up.
Just blocks it. But this is actually something different. That's an electrical.
It's an arrhythmia, but you can have the arrhythmia with the heart attack. Usually what happens is if the patient is identified, and cardiologist is usually involved, that's the heart doctor.
Okay.
The heart doctor will look at the heart, see if there's damage, see how the pump of the heart is, maybe do the monitor for arrhythmias. Right. And people who are at risk for sudden cardiac arrest will then get an implanted defibrillator. It's a little box. It's like a pacemaker.
Really?
But versus just beating to keep the heart beat, okay. It will actually shock the person back if their heart stops.
Wow, which is different from a pacemaker.
Yeah, but they're in the same ballpark.
Same ballpark.
It looks like a pacemaker. It's implanted similar to a pacemaker. Okay. But it's not just firing to keep the heart rhythm.
Right.
It actually will shock the heart back to life.
Okay. And so without that defibrillator, that implanted device, that if a person goes into that arrhythmia, he just dies.
Yes.
Right on the football.
And that's 95% of the people who go to sudden cardiac arrest will die. So these things can be life-saving. It's the Association of Black Cardiologists and the Heart Rhythm Society. These are two different groups, both for cardiologists. We're mainly dealing with health disparities at the Association of Black Cardiologists. The Heart Rhythm Society deals with sudden cardiac arrest and atrial fibrillation, all sorts of problems related to the heart rhythm. And together these organizations are increasing awareness, especially in the African American community, because just like so many diseases that you probably have been looking at over the last several years, they're hiring African Americans.
Yeah, and I know you've done a lot of work in being able to help people understand why are they high in African Americans. And in fact, you're actually one of the forerunners to help people understand. I think, I'll never forget, there was a drug that came out that was supposedly specifically for African Americans, but you were able to do some articles to help us understand that. Can we interject a little bit of that in it?
Yeah, well, we looked at heart failure in African Americans, and we saw a combination of medicines, isosarbide nitrate and hydrolysine. These are big names. These are older medicines, actually, but they open up the circulation. They're called vasodilator. Vasal meaning blood vessel, dilate means to open up. And we added those medicines on top of the regular medicines for heart failure, and it seemed to help African Americans. The problem is the drug was then labeled only for African Americans. That really wasn't our intent. We studied it in African Americans because that's a higher risk population. But I certainly don't think you should look at skin color or racial or ethnic origin and just say that drug for these people. That's too simple. Life is not that simple. We're all the same.
So it's not as if black people have black blood.
Yeah, no, that wasn't. I'm not sure exactly why that happened. Maybe I'll come back and we can discuss the history behind that. It's really involved. And I've gone, to various large academic centers and discussed on panels about why it was done and was it done correctly. But here's the problem: African Americans have more hypertension. They have more heart attacks. They get them earlier. They get less care, less access to care, less health-seeking behavior, less referral to specialists, less use of these devices that can be life-saving. You put that, we call that a gumbo in New Orleans. You put all that stuff in, but here's the toxic gumbo. It's a bad gumbo because you have more risk factors, more disease, less access, less specialists, less use of life-saving devices, and it leads to worse outcomes.
And therefore, a strong awareness campaign to particularly target, not everybody, but particularly the African-American community.
That is correct.
And what about African-American males? Is that even a greater subset?
Well, African-American males have the highest heart disease death rates. But, women live longer than men. So the men die, and then the women who are now older get heart disease. So if you look at the total burden, it's as many women as men because you have more elderly women than men. The men die sooner than the women. So I think it's an equal opportunity killer. Whether you're a black woman or black man, you should know about sudden cardiac arrest. And that's why we have arresttherisk.org. It's a website, and a person can go to and get more information.
If I can ask you this too, how detailed should people understand the information?
I'm not a doctor who's bothered by that. And I've always felt, and we've discussed this, that people shouldn't know their disease, know their medicines, and I know you as a pharmacist, even before people came on clipping little stuff to the bags, you were talking to people beforehand. So you were way ahead of that game. I think knowledge is power. A person then can know their condition and make appropriate decisions. Even with medicines, all those side effects, they're able to tease out how many of those side effects are actually affecting them. Because it doesn't mean if you have a page of side effects, you're going to get them all. But you still should know. Because you may be able to notify the clinician, the doctor, or the nurse practitioner, hey, look, I'm getting swollen lips and swollen faces. I'm on an ACE inhibitor. And that might happen on a weekend. It might happen on a holiday. And you're already aware of it, so you're able to inform the doctor and stop the medicines versus saying, well, I don't know what's wrong. Maybe I had a bee sting. Maybe it's the pollen in the air. So health information, I still think, is very important.
I think it's major because what happens is that if we just say, back off on salt. People need a bigger picture. They need to understand why and what's going on.
Well, we were discussing that. The 1,500 milligrams is a very low salt diet. It's recommended for all people with hypertension and all adult African Americans. You say, well, that doesn't make sense. There are some African Americans who may not need a very low salt diet. For instance, if they're very active, have a very good diet, don't have hypertension, no obesity, but that
demographics don't point.
It's easy just to say African Americans eat less salt. That's a better message than trying to carve out all of those little specialists. And now, in terms of the sudden cardiac arrest, the patient really doesn't know. They have to go to a specialist. And we think referral to specialists is something that absolutely is necessary if you have a history of heart disease, a family history of heart disease, especially if you've had congestive heart failure, where the heart swells, it doesn't pump as well, you retain fluid, short of breath. Just taking a diuretic, a fluid pill, and getting the water out, you might feel better, but you still might be at risk.
So we're looking at family history of heart disease.
Very positive.
Very important.
Very important.
Because of the genetics or
there are some genetics, believe it or not. There are some people who develop heart failure because of genetics and actually have an increase in sudden cardiac arrest because of genetics. So there are families where people die suddenly. And I know you've probably talked to someone, my daddy died at 50.
That's right.
My uncle died at 50. I'm 48 and I'm scared.
Right. That's right.
That is real.
Okay.
But for most people, I think the genetics is there, but for most people, I think families have certain lifestyles that cluster together.
Major.
Everybody likes to eat the same type of greasy, salty food.
Right.
There are certain health habits that go together. They may not identify risk factors the same.
Exactly.
And those health habits then can lead to adverse outcomes. So what we're trying to do, we're going to 10 cities, is get the message out, especially to African Americans, because you have higher rates of heart disease and sudden cardiac arrest, that they should be aware of it.
And they should see a general practitioner first, an internist first. Everybody
should have a primary care.
That's
there are not enough specialists to go around anyway.
Okay.
But if you've had a heart attack, if you have had congestive heart failure, if you have severe hypertension, then you might have something going on internally and not know it. That's when the specialist comes into play. But certainly, I'm not making the case everybody should go to a cardiologist.
Okay. So, but the primary care physician should know when to refer off.
That's correct.
Okay. Is that happening enough? Just not to create trouble.
Yeah, they've done surveys, and apparently, the great majority of even primary care providers don't talk to their patients about sudden cardiac arrest.
Okay.
Because the patient might look good.
Okay.
And again, I go to your expertise as a pharmacist. You have people you know because they have this bag of medicine.
Right.
They look all right. They feel all right. But then, you call them about their refills and they say, Mama died last week. You can die suddenly and feel pretty good right before you die. And that's why we want people to understand we're dealing with risk and not symptoms. Symptoms are important. Everybody wants to feel good. But you can be at risk of dying suddenly and feel pretty good.
And we have to focus on that because most people, particularly with hypertension, if I don't feel bad, if I don't have a headache, I must be okay.
And then if the medicines have any side effects, they stop the medicines because the medicines, quote, make them feel bad, whereas we have 126 medicines. The answer is to have a good relationship with your provider, and he or she can give an alternative medicine or change the dose or change the combination. But again, African Americans sometimes will have less adherence. There may be the daughter who flies in from California, or Mama, you don't need to take that medicine.
That's right.
And she's not a doctor.
That's right.
She hasn't even been going to the visit. Mama, you don't need to take that medicine.
That's right.
And those are the type of things that we're trying to combat.
Yeah, because people, they have a number of different myths. Is that, hey, I'm taking too much medicine. I'm taking 3 blood pressure pills. I don't need but 1, so therefore I'll only take that 1. But
the placebo-controlled trials means you give a sugar pill, and then you give a person a blood pressure pill.
Okay.
Or you give the person a sugar pill and you give the person an ACE inhibitor, an angiotensin blocker, or a beta blocker for heart failure. The people who take the sugar pills die. Those studies have been done. I've done clinical trials. I wouldn't put one of my patients in a study with placebo for blood pressure right now. It's been shown conclusively that if you have elevated blood pressure, you have a history of heart failure, there are medications that can be life-saving. Case closed. And that's part of God's plan. We wouldn't be able to do that if it wasn't right for us to do it.
That's right.
And that is why we're different from brute animals. The ability to change our environment, that free will that humans have, that makes us something special. To turn our back on that and not utilize technology like the implantable defibrillator or utilize medications, to me, doesn't make good sense.
I think that is key. I would say, if I can jump there, I want to because from a physician standpoint, from the medical community, we must approach this holistically because those are the things that are stopping people from taking their medicine. Those belief systems that don't line up with common sense. Yeah, I think it has to be discussed because people don't take medicine because they feel that, hey, God's going to heal me tomorrow, and so I don't take my medicine, or I'm not going to take all of them. Why take something that's going to make me feel bad? Unless we address those things, we don't move forward. So.
I'll tell you a little thing I use with patients, and when we had Heartbeats Life Center, we had thousands of patients.
Right.
And I often use this example. I say, you ever been in Los Angeles? Because people from New Orleans tend to go to the West Coast. They got aunts and uncles, et cetera. They say, yeah. I say, did you walk? And they'll look at me kind of, puzzled. And I say, oh, you flew. So you use the technology to go visit Aunt Minnie. You won't use the technology to save your life.
Literally, yeah. We miss it because the thing of it is we don't want to take the medicine anyway. They really don't want to.
Yeah.
And so they're looking for any excuse to not take it.
I think the thing is to know side effects, but recognize also indications and know what you have.
Okay.
So we're going to 10 cities.
Okay.
I'm gonna see if I can get all 10, because there are 10 cities that have mainly black populations, and many of them are cities where people from New Orleans have relatives. Many
right.
people from Katrina went to these cities right around New Orleans: Dallas,
okay.
Jackson,
right.
Nashville, Atlanta. Some people going up to Detroit,
yeah.
Washington, Baltimore.
Okay.
Oakland, which is way on the West Coast, but has a lot of black people live in Oakland.
Okay.
And of course, New Orleans.
New Orleans, that's right.
That's
Atlanta.
And Atlanta.
You mentioned Atlanta. Okay. Yeah. It has to be, right at Atlanta where we play football with them and the whole bit.
So what you're trying to do when you do these type of campaigns, Association of Black Cardiologists and Heart Rhythm Society,
right.
You're looking at populations
right.
where you have a lot of people who are at risk,
right.
and you're trying to educate those populations to know your risk,
okay.
so that you can arrest the risk of dying suddenly. And the way you do that is, if you know you have heart failure, you ask your doctor, should I see a cardiologist? Or how is my ejection fraction? How is my heart pumping?
Good. Good.
And that's important because people who have very, very low ejection fractions, where the heart's just kind of going like this, usually 50% of what you have inside your heart, you pump it out with each beat.
Okay.
If you're only pumping out 15, 20, 30%, and your heart's very weak,
okay.
and you have been shown to have this condition for over 6 months, it's a persistent condition,
okay.
then you might be a candidate, not you, but that person
that's right.
might be a candidate for an implantable defibrillator.
So that's big. So know your ejection fraction, or at least be able to ask your physician, hey, what is my ejection fraction?
Right.
Let's talk about other things. You said a family history, and what's next? Family history?
Hypertension we talked about.
Hypertension.
Now, heart attacks are important, even though I tried to separate sudden cardiac arrest from heart attacks.
Okay.
Having heart attacks is important, and that's directly related to lipids, which is cholesterol.
Got it.
And that's when you get into the whole cholesterol story. But sudden cardiac arrest,
right.
while it's related to the heart attack, you can have it with the heart attack. You can also have it if you have congestive heart failure and the heart's pumping weak,
okay.
but you don't have blockage. And you see that in African Americans. More African Americans have heart failure related to hypertension versus the heart attack per se.
So a person could have normal cholesterol levels, normal triglycerides, no fat in the blood,
right.
And
do an angiogram and don't see any stenosis, any blockage, and still have congestive heart failure.
Because of hypertension?
Hypertension. Well, I can give you the mechanism.
Okay.
So when you put the cuff on, you're measuring the pressure in the arms.
Got it.
The heart has to pump against that pressure.
Okay.
So it's as though you had a big rock and you're trying to roll it up the levee.
Okay.
And you roll it up. Every time you roll it up, it rolls back. So the heart's pumping against that 180 over 120.
Right.
Now, you might feel pretty good.
Right.
But with time, you can tear a blood vessel in the brain.
Right.
You damage the kidney with that pulsatile pressure.
Okay.
And the heart itself starts to dilate and enlarge as it gets tired, and it loses its ability to pump forward. That's what heart failure is. And it's those persons, whether they've had a heart attack or not,
right.
You can just get that with hypertension. You can also get it with diabetes.
Right.
It's those persons who are more prone to sudden cardiac arrest. Hence, they should be evaluated by a cardiologist regardless of how they feel.
Maybe I might be off track, but I have to ask, tell me about this hypertension with no added lipids in the blood, normal cholesterol, normal triglycerides,
yeah.
But it's tight. The vessels are tighter.
Well, first of all, we really don't know what causes hypertension in many cases.
Wow. Okay.
And so many times, that's why they call it essential hypertension, because they thought it was something that was essentially part of a person's makeup. Right. But there are certain things that will increase. Physical inactivity. If you sit around all day watching soap operas, you may increase hypertension. Okay. Psychosocial stress. Psycho meaning the brain, social meaning the environment, the society. That might increase stress. And some people think that psychosocial stress actually increases the risk in African Americans, especially in urban environments.
Right, gunshots.
Gunshots, ambulance,
right.
Person next door fussing and fighting.
Right,
you really can't sleep, you can't rest. Right. You tell your elderly patients, I want you to take a walk in the morning. They say, no, I don't go outside. I go to church, somebody picks me up, but I don't, that's it. They bring me my food. You know, somebody goes to the grocery for me, I give them a little list, but I don't go outside. So those things can increase your risk. Salt increases your risk.
Okay.
There's a debate that everybody doesn't need to be on a low-salt diet. That's probably true. Okay. But anyone who has hypertension or a strong family history, especially African Americans, it's very common.
That's right.
And I'll give you the percentages in a second. Those patients will benefit from low salt. So you can have stress, elevated salt, obesity, physical inactivity, hypertension, but if you drew blood tests for cholesterol, triglycerides, the lipids, they could still be normal.
Wow.
And you can go into congestive heart failure with hypertension that's prolonged and hasn't been treated appropriately and not have blockage. So the blockage is important, but just because you don't have blockage doesn't mean you can't develop heart disease and you can't die from it.
Wow, so those vessels can be clear as a bell,
yes,
but still cardiac arrest.
That's correct.
Or can have a stroke.
That's correct.
Amazing. People have to see a doctor.
You know, I think the problem is that many times doctors don't talk to patients and explain what they're doing and why they're doing it. Right. So there's a barrier there. It's a communication barrier. I'm not going to put it all on the patient. Okay. But at the same time, if you have these conditions, you do benefit from medicines. You do benefit from the technology. Right. It's in the public domain, so I'm not talking out of school. Somebody like Dick Cheney, he's had the defibrillator, he's had angioplasty, he's had bypass. They even gave him a new heart, kind of elderly for that. But I mean, he used that technology and he's still around.
Still around.
And he would not be if he's just stood at home, no, I don't want to go to the doctor, no, I don't want to take the medicine, no, I don't want to have this device. Those things have helped him live a long time.
Okay. Now, well, let's look at this. Hypertension, you know, we do the free screenings all the time. Yeah. We have guys come in, you know, 240 over 120, just numbers through the roof, and they say, man, I feel fine. I said, no, I need to call an ambulance. I feel fine. What is going on with it?
Well, we call it the silent killer, because especially for many people, they can have pretty severe hypertension and not feel it. But here's what I've found. If that person gets treatment and you lower blood pressure, they actually feel better. Because sometimes they have dull headaches, they have memory loss, they have fatigue, they get shortness of breath when they try to work, because remember, the heart has to pump against that elevated pressure, so they try to do something and they get tired and short of breath. You lower the blood pressure, you make it easier for the heart to pump and circulate the blood, and the person feels better. Then they say, you know, I always thought that that's the way I normally feel. I've been down so long that down looks up to me. You know,
that's the song. Yeah,
it gets you get used to it.
Right.
And we really should never get used to feeling bad. We should never get used to being sick.
Almost through prevention from the whole thing. How do we prevent this whole thing from going into this entire cascade?
Well, remember, you have the Association of Black Cardiologists, you have the Heart Rhythm Society. Heart Rhythm Society mainly deals with the procedures. Those are electrophysiologists, and you had one of my colleagues on talks about that. The Association of Black Cardiologists, we deal with that too, but we also go to the prevention side.
Okay.
And I'm going to do it really quick. Spiritually intact, low sodium, low fat diet, physical activity, attempt to maintain good body weight, know your blood sugar, control it if you have diabetes. Those simple things, if you did that, it would help.
Well, I will say, and I have to say it, you can have great taste at 1,500 milligrams.
Yeah.
All right, because you can get up to 1,000 milligrams, say like for one meal, say 700-800. You can get like a 200 milligram on a breakfast and maybe 300 milligrams right at lunch. That's 1,500 milligrams. And so people can have great taste right there. Low fat, just stay away from the fried foods.
Right.
And that's pretty simple. So people can eat well, and they can exercise and still do well.
But if they have heart disease, if they've had congestive heart failure, they've had a heart attack, they need to see a specialist.
They need to see.
Yeah, just because you're, quote, feeling all right, you still have an increased risk. And that's why we go back to the campaign. The campaign is designed to identify those people who had increased risk so they get appropriate treatment.
Good. 3 more minutes. Arrest the Risk. Okay, that's on the screen.
ArrestTheRisk.org. It's nonprofit. They go there and they can just tool around. There are tools there with questionnaires, and they can get more information about heart disease. there's no cost for that. This is something that's being done as a service by the organizations to inform people about what's going on with them.
Right. So this relationship with the physician is very, very key.
Very key.
Even without healthcare, they have clinics that people can go to or whatever.
Well, New Orleans is actually developing, several low-cost clinics.
Right.
The Daughters of Charity has some, and there's some other clinics around where if you don't have insurance, you can go get. I'm not going to say they're free. There may be some cost. St. Thomas Health Center, in the Old Irish Channel. So I think right now, if you don't have insurance and you have a difficulty maintaining the cost of care, there are places in New Orleans where you can go.
And physicians can work with you on the medications that you get, because there are some of those medications that you need. I mean, they're pretty cheap. Yeah, you can get generics that are pretty cheap. So you work with them where they don't have to take the $175 drug that if they can't afford it, they can usually get good treatment.
And then what is the cost of life? African Americans have these huge death gaps where we die quicker, and it's not just drive-by shootings are bad, murders are bad, but we're talking about over 350,000 people die each year from sudden cardiac arrest. 95% of them don't make it to the hospital, and more common in African Americans, every 90 seconds. So we're talking about a big problem, something that people need to be aware of. And everybody has somebody in their family with heart disease or congestive heart failure. They need to make sure they keep a relationship with a specialist.
So one thing, if I want to go out and help people, what's the main thing I need to ask people? To ask them, do they have a doctor, or what can a group do? Say like a church group or a social organization. What can they do for their members?
Well, the Healthy Heart Community Prevention Project, and my wife Daphne Ferdinand is running that now. We've had that for many years. We used to do the Bayou Classic, etc. I always believe you don't just do the screen. You have to do the education and then integrate the person into the healthcare system. Let me break that down. Don't just check the blood pressure. Make sure they got some place to go.
That sounds good to me. Hey, 1 minute left. Let's do that take-home message.
Well, the take-home message is, if you have a history of heart disease or a strong family history, tell your doctor. And especially if you've had congestive heart failure, had a previous heart attack, even if you feel okay, you still may be at increased risk for sudden cardiac arrest where your heart just stops. There are devices, there are means by which you can actually decrease the chances of dying suddenly and unnecessarily. So we have this campaign, Arrest the Risk. And you go to this website. Those of you who don't have a computer, there's a 14-year-old somewhere in the world who can do it on the phone. Arresttherisk.org and get more information.
I'm just excited. Hey, health issues. This is Dr. Keith C. Ferdinand. We thank him. We appreciate him. Let's do what we can to help somebody, and have a great day.